Hello everyone, myself Dr. Priyanka and I'm one of your mentors for study MRCPI. So we are back with the OMR series, third OMR series 3, where we will be discussing the important OSCE stations. And today we'll be discussing the Urogynaecology station on the pelvic organ prolapse, having the urinary symptoms. So do like, share and subscribe Study Medic channel and also press the bell button icon. So always do remember that your success depends upon your drive, your determination, and your commitment and your appreciation for yourself. So believe in yourself, keep preparing, keep practicing the stations, and then definitely success will be yours. So this is the structured discussion where I will be the candidate and Dr. Soumya will be my examiner and who will be giving me also the feedback. So hello, Dr. Soumya. Thank you for joining.
Hi, Priya. Thank you.
So I will start.
Yeah.
Hello, I'm Priyanka and I'm one of the exam candidates. I have read the scenario and I'm ready for the discussion.
Okay. What information would you elicit from Mrs. Smith?
Yeah. So Mrs. Smith has come with the complaints of something that is coming, dragging sensation vaginally. So here I would like to ask, since when she is having the symptoms, the duration and the severity of symptoms, has the symptoms changed over the time? And has she taken any treatment so far for the symptoms? And how much it is affecting her quality of life, I want to ask. Then regarding the, I want to ask if it is, if she is having any urinary symptoms like any dribbling of urine or any increased frequency or burning micturition or if there is associated incontinence. Also, I would like to ask regarding bowel symptoms, like is there any constipation or incomplete evacuation or if there is any fecal incontinence. So this I want to ask. Then she's 62 years old. So here I want to ask about the sexual history, like is she sexually active? And if yes, so does she having any discomfort during the intercourse? And also it will help me plan regarding the management because if it's a prolapse, so then she chooses any pessary, so we can plan a ring pessary for her. Then regarding her menopausal status, I want to ask, since when is she having menopause and how many years? And is she taking any HRT? And is there any history of postmenopausal bleeding? So that I want to ask. Other things are the allergies and also habits history. Does she smoke or take alcohol or any recreational drugs for fun? Then I would like to inquire about her medical history, especially conditions like asthma, COPD, which can increase the abdominal pressure and cause prolapse. So I want to know that, and others like diabetes, hypertension, and any surgeries in the past, like especially any pelvic surgeries, if she had any previous pelvic surgeries. And obstetric history also is very important in this case because how many number of kids does she have, and what was the mode of delivery? Was it a vaginal or a cesarean or an instrumental delivery, which can increase the risk factors for prolapse? And what were the baby weights? Did she had any pelvic floor exercise after the delivery? So I want to ask that. And her BMI, I want to know because the high BMI is also a risk factor for having a prolapse.
Okay. Okay, fine. Can you move to the next slide? Okay, so she has been bothered by the urinary symptoms and mass per vagina for the last few years, but aggravated since last 6 months. There is frequency of micturition, but no incontinence. She has not tried any treatment. She has 4 kids, all normal deliveries, no postpartum similar complaints. She has no allergies, no comorbidities so far, but she smokes cigarettes like around 10 cigarettes per day, and she is sexually active. So take me through the examination. What would you want to do?
So here first I would like to take her verbal consent for the examination and tell her to first of all empty the bladder, and then I would like to wash my hands and put on the gloves and then stand on the right side of the patient and do first a general examination for her. Want to check her pulse, blood pressure and the BMI. Followed by the local respiratory system and cardiovascular examination, followed by abdominal examination to look for any masses, any tenderness, followed by the local examination and the speculum examination to also quantify the prolapse. First, I would like to do all the POPQ classification. So all the points that are on the grid, that is the 9 points. So out of that, except TVL, I would like to do when there is prolapse, and then I would like to reduce the prolapse and would like to measure the total vaginal length and would like to do the per vaginal examination for her.
Okay. So what are, because you mentioned the POPQ, what is the POPQ and why this system is beneficial when compared to the other methods?
Yes. So POPQ is a pelvic organ prolapse quantification system. So here this is an objective way of classifying the prolapse. So that's why the inter-observer variation is less compared to other methods. Also, the outcomes of the surgical repairs are quite good if POPQ is used. And also here the hymen is taken as a reference point. So here anything the anything above the hymen is the numbers are given as negative, meaning that there is less chance of prolapse, and the points are below the hymen are given the positive numbers, which denote that there is prolapse, either anterior wall or a apical prolapse or a posterior vaginal wall prolapse.
Okay.
Also, it's used in publications. The POPQ system classification is used in publications.
Fine. So if you could move to the next slide, this is the POPQ done for Mrs. P. Smith. So what is the diagnosis and what is the diagnosis first?
Yes. So here I can see that the posterior vaginal wall is well supported here. The more the minus points, the well supported is the vaginal wall, and also the genital hiatus, the perineal body, and the total vaginal length are in the within the normal limits. But here, as we can see that the on the anterior vaginal wall, the AP and BP points are at the zero level. So it means that it is a stage 2 anterior wall prolapse, that is the cystocele, where zero because stage 2 because the stage 2 of the POPQ system is when the prolapse is between -1 to +1 of centimeters of the from the hymen.
Okay, what are the management options for Mrs. P. Smith?
Here, it depends upon various factors like her preferences and also any comorbidities if she is having. So here again, first is the lifestyle measure, the first slide. Here, I would like to suggest her to, as she is a smoker, she smokes 10 cigarettes per day. So here, I would like to do lifestyle measures like stopping smoking, and would like to refer her to stop smoking services. And regarding her BMI, so if the BMI is high, so I would like to offer her referral to the nutritionist to lose weight, because that can improve the symptoms of prolapse. And the second is the pelvic floor muscle training, which is usually done for 16 weeks, 8 contractions 3 times per day for 16 weeks in the case of prolapse, which helps in the recovery of the pelvic floor muscles. Then the other thing is the pessary. So if she is sexually active and she is willing for pessary, I would like to give her a ring pessary. And there is a combination of treatment where both the all the lifestyle measures plus the pelvic floor muscle training and the surgery can be given. So surgery is here, the main surgery is here is the anterior repair, that is the cystocele repair, along with which a vaginal hysterectomy is also done.
Okay, take me through the steps of vaginal hysterectomy with anti-wall prolapse repair.
Yeah. So here, any surgery starts with the pre-op management. So pre-op, she will be proper history. I would like to take her, and also would like to do an examination and in the presence of a chaperone, and would like to do some investigations for her. So here, I want to know that her blood parameters are optimized. Also, I would like to refer her to anesthesiologist for the fitness before the surgery, and any her health should be optimized. After that, then during the time of surgery, so that time examination, cleaning and draping is done and she should be placed in the lithotomy position. Followed by an examination under anesthesia is preferable. Doing the POPQ again and classifying the prolapse will be beneficial. And then the WHO surgical checklist, the time sign in, time out, and sign out should be always during the surgery should be filled out. Then the cervix is held with the Alice or Valsalem forceps. Then the circumferential incision is given on the perivesical fascia, and then on the POD, where either a blunt or a sharp dissection is given to incise the POD. But we have to make sure that there is no injury to the surrounding organs. After that, the POD is open, and the first is the uterosacral ligament, which is clamped by the Cocker's forceps, and then cut and then sutured. Later, after the vault is removed later in the later stages, and then we can suture this uterosacral ligaments to the vault to prevent vault prolapse. After the uterosacral ligaments, then is the incision of the then is the step of the uterine arteries, where the uterine arteries are separated and clamped and cut, and we have to make sure hemostasis is proper maintained. Then is the step of the infundibulum pelvic ligaments, where they are clamped, cut, and ligated step by step. And then is the steps of the uterus, the specimen delivery, after which the cystocele repair is done, where the anterior vaginal wall is incised, and then the bladder is repositioned, and then the any excess anterior vaginal wall is removed, and then the remaining anterior vaginal wall is reinforced with the sutures to the bladder. Then the final step is the vault closure, where the uterosacral ligaments are ligated with the vault. And then is the post-operative period.
Okay, so how would you go about managing post-op?
Yeah, so here I would like to monitor the patient vital signs, especially on the IMUS chart. I would like to watch for any pain or any infection signs or any bleeding, especially in this patient. Then pelvic rest should be given. Also, I will, and VT risk prophylaxis is very important. Input-output charting. And also debriefing, documenting is very important. And any untoward incident has happened, then I would like to do duty of candor and incident reporting. And I will like to give the follow-up appointments for her, and also consultant appointment in the next time.
Okay. So I think what there was almost like like I would say 15 seconds, there was an extension because we are done with the 10 minutes. So the only thing is what I felt was probably few things. Okay, it went on very well because you could recognize a lot of things. I think history taking, if you could have reduced, because it went almost 4 minutes, Priya. But I really liked about the quality of life which you mentioned. Probably treatment taken so far is something which I thought you missed. Other than that, in the examination, post-void residual is something which we all of us need to be careful about, which we need to mention. Urine examination, and also because it's prolapse, don't forget to mention about the gait. Rest of the things, I think POPQ. There also you went on for a longer time mentioning how to do the POPQ. That was not required actually. So if you could have just told me POPQ. And the next question when I asked what is POPQ and what are its benefits, again, you went a little bit, probably I didn't ask you the top points, how to measure. So what is POPQ? It's a more objective system. So you could have cut short. That's the reason I felt for the rest of the questions it was not enough. But I think you did fairly well. So I think probably, I'm sure you would be showing the answers as well. It is a clear pass, but only few things here and there. Okay, thank you.
Thank you so much, Dr. Somo.
Thank you.
Oh yes, so here in her history, so very important knowing is, so since when is she having the symptoms, and how severe it is, and how it is affecting her quality of life, and if she has taken any treatment so far is very important. And the associated symptoms with the prolapse, like any urinary symptoms, bowel, any sexual symptoms if she is sexually active, knowing that is very important. And also then further is the medical surgical history, menopausal status, and especially any history of any post menopausal bleeding, knowing that is important. Any allergies as a patient, as a safety point. Also smoking, as this patient was a smoker, so smoking can increase the abdominal pressure. Any high BMI can increase the abdominal pressure and can worsen the prolapse symptoms. So knowing that is very important in history takings. So coming to the examination, so yes, it is a stage 2 anterior wall prolapse, that is cystocele, because the AP and BP points are at the level of the hymen. So there is a cystocele stage 2. So the benefits of POPQ are that it is an objective way of classifying the prolapse, and their outcomes are very good for the surgical repair. And it is an objective method, so the examiner variability is less reduced. And also in the publications or presentations, it is most commonly used. And because the error is less, because the hymen is used as a reference point. So anything above the points above that is negative, and anything below that points are positive. So what are the management options? So always first is the lifestyle measures, which is by proper weight loss, which can improve the symptoms. Any conditions like which increase the abdominal pressure, like any medical conditions like asthma, COPD, high BMI, or smoking, which can increase the abdominal pressure. So they needs to be modified, which can improve the connective tissue health and also overall well-being. And then is the pelvic floor muscle training. So she's a case of prolapse. So here in this case, it will be 16 weeks. And that will also strengthen the pelvic floor muscles, and followed by pessary if she is willing, and if she is sexually active, it can be a ring pessary. And that combination of treatments can also be given. And the surgical option, last option, is the anterior repair, cystocele repair. So steps is, yes, here first always it is any surgery, there is a pre-op evaluation. We have to optimize the patient's health. Also, it is a multidisciplinary team involvement. So we have to involve the senior consultant, anesthesiologist, the OT staff. And here the pros and cons of the surgery should be explained to the patient. Proper written consent should be taken. And at the time of surgery, WHO surgical safety checklist is very important. And then the patient is positioned and draped, followed by examination is done, especially after the anesthesia. And then the cervix is manipulated. So here then the next step is incising and opening the pouch of Douglas, followed by then the uterovesical pouch, which is dissected to separate the bladder from the uterus. And then are the uterosacral ligaments, which are clamped by the cockers and then cut, and then ligated. Then is the uterine artery strap, followed by the infundibulopelvic ligament, and then the uterus, the specimen is delivered, and followed by that the cystocele repair is done. So here any excess anterior vaginal wall tissue is removed. The cervix, the cystocele is, the bladder is repositioned in the normal place, and then there is a reinforcing of the anterior vaginal wall to repair the cystocele is done. And final step is to close the vault, and also making sure that there is proper hemostasis. And to prevent further vault prolapse, then the uterosacral ligaments are sutured with the vaginal vault. So these are the steps. And in the post-operative period, I forgot to mention the enhanced recovery program that can also be incorporated. So here we have to watch for the bleeding, infection, and pain, and IMU starting should be done. Also input, output, and pelvic rest should be given. Also, venous thromboembolism prophylaxis should be given, and always the documentation should be done properly. The patient should be debriefed properly, and follow-up appointments with the consultant should be given.